So let's jump in. I want to introduce myself. My name is Ali Guajardo. I identify as a trans man. My pronouns are he, him, él. I'm a licensed clinical social worker, currently working at Santa Barbara Neighborhood Clinics, where I'm a behavioral health provider, providing therapy and consultation for various different folks, but specializing in LGBT healthcare. I graduated from Rutgers in 2015. And after I graduated, I moved back to the Santa Barbara area and have been working in the county since. So I have over 6 years of applied crisis care with programs such as Wraparound. I worked for Wraparound for years, both as a family facilitator and a clinical supervisor. I've also served as a backup supervisor for the safety program, which is Santa Barbara Mobile Crisis Unit. I've worked with populations such as commercially sexually exploited children, Brown, Indigenous people of color, and gender diverse children, adolescents, and adults. I have been trained in several different approaches, trauma-informed care, motivational interviewing, cognitive behavioral therapy. However, for this training, I'm going to focus on my 5 years of training in eye movement desensitization reprocessing, EMDR, and 3 years of dialectic behavioral therapy. In my experience, I have found that DBT and EMDR are the most effective when treating complex trauma. And given that our marginalized communities navigate intersections and various forms of trauma, I found that DBT and EMDR tend to be especially beneficial when working with this community. And then on a personal note, I am a former foster youth. I grew up to 2 parents who were both addicts, who had untreated mental health concerns. And also, while I was in foster care, I witnessed my 2 younger brothers navigate the system. They had been traumatized, removed from home by the age of 7 and 9, and they did not really understand why we were removed. So what that meant often is that they expressed their grief, their anger through external behaviors, aggression, breaking things, fighting. And I just saw that it was a cry for help. And very often my brothers were met with law enforcement or psychiatric holds and taken to medical hospitals, when really growing up, I saw that they just needed mental health services. So that's kind of what brings me here today, both my work experience, my education, but as well as my personal experience. So I hope what I bring to you today is kind of an eclectic approach to navigating crisis care. So for today, what I'm hoping that we're going to learn is going to be that you all will kind of see why the current crisis continuum of care is problematic. We'll also learn about risk factors and vulnerabilities that lead to increased mental health concerns for LGBT and BIPOC people. I'm going to teach you an Act Quick tool for responding to an active crisis situation. The Act Quick model is something that I use in everyday crisis response, and I've been using that for the last 5 years. You will also learn intersectional responses to mental health crises in order to reduce arrest, psychiatric hospitalizations, and use of emergency rooms for the LGBT and BIPOC community that accesses crisis care. I will be teaching you this through a case study. So I'm going to apply theory and intervention while kind of showing you how this looks in practice. I do want to say that I will be teaching you skills that are pulled from the EMDR model as well as the DBT model. And although you will be taught some skills here today, I just want to emphasize that this training will not serve as a certification in DBT or EMDR. Instead, these skills that I'm teaching you today are skills that I have been able to teach families while I worked with Wraparound, paraprofessionals, natural and community supports, because the reality is that we need to be relying on natural and community supports as opposed to law enforcement and medical facilities to manage and help us with crisis care. So as you can see here in this model, this is our current problematic crisis system. So this current system contributes to inequitable health outcomes for marginalized communities by increasing rates of criminalization and incarcerated, and incarceration instead of stabilization and support. The ways we deal with mental health crisis situations is a clear example of how we currently over-rely on police and prisons. We live in what activists and academics like Angela Davis call a carceral state, which basically means that we deal with all social problems through policing and prisons. So that includes homelessness, addiction, mental health crisis. Our first response is often the police, and we've seen the results that this has on marginalized communities, including high rates of criminalization and incarceration for people who need care. Right, so I invite you guys to think about what this looks like in your community. You know, is this the current model that your community, your agency, your staff are currently using, or have you all seen a shift in what this looks like? Right, for myself here at the clinic, I can tell you when I first came on about a year ago, a lot of the ways that we were responding to someone expressing suicidal ideation was very often to call the crisis hotline, right? Get the mobile unit to come into the hospital and respond, or we would triage them to the ER and take up a bed. Or being at my clinic, we're right across the street from the police department. So very often it was just call the police. And this is an issue, right? This is why research shows and statistics show that LGBT folks, as well as BIPOC folks, tend to refrain from seeking supports and helps because very often they're met with a system like this, which does not validate and does not support them in what they need. So I'm very happy that we are living in a world right now where we are seeing a shift in this current crisis system, right? So what this looks like right now, what we're seeing through the shift, and again, I invite you guys to think about what this looks like in your community, but this may be your community that has developed warm lines or crisis lines, right? We see the text line for a crisis, there's online chats and phone numbers that we can call. We also have behavioral health response, like if you're in a program such as Wraparound that provides crisis care, mobile crisis units like here in Santa Barbara, Safety, residential programs, psychiatric hospitals. We may even see medical responses like trips to the ER, clinics, and crisis stabilization, as well as inpatient and outpatient services. And even more importantly, we're now seeing the shift in how law enforcement is being taught to respond to a crisis, right? So here in Santa Barbara, we have partnered with the law enforcement agencies, and we now have a mental health worker. So all of them receive trauma-informed training, and when they are responding to a crisis, they most of the time have to respond with a mental health worker who's trained in kind of understanding crisis and can intervene when law enforcement steps back. So when we look at statistics of rates of considerations and attempts for suicide amongst the LGBT youth by race and ethnicity, we can see very clearly what's happening here, right? We have 12% of white youth who attempted suicide in the last year compared to 21% of Native or Indigenous youth, 20% of Black youth, 19% of Middle Eastern, North African youth, 17% of multicultural youth, and 16% of Latino youth, and 12% of Asian American or Pacific Islander youth. So we see here by race, you know, maybe the more one falls in this hierarchy, right? If you are white, middle class, that is kind of the area of privilege. So as we see this layers of oppression kick in, we can see these numbers shift by race. I also want to point out that while I was doing research for this, I found that the Trevor Project had also just released some studies on LGBT youth mental health, which really shed light on the unique challenges that LGBT youth face. So what that looked like was 40% of LGBT youth considered attempting suicide, with more than half being trans or non-binary. 68% of trans or LGBT youth reported symptoms of anxiety, including more than 3 out of 4 trans and non-binary youth. 48% of these youth engaged in self-harm in the last 12 months, with over 60% of those being trans and non-binary youth. So what this really points to, these statistics, again, our LGBT youth, BIPOC youth are navigating various problems and concerns that can be political, environmental stressors, maybe isolated incidences that happen to them specifically, you know, depending on the geography or geographic location that they're in. And I'm going to complicate this a little bit, right? Because I'm also talking about the criminal justice system. So right here, we can see the percentage of trans people who are reportedly being harassed by police by race. So LGBT people are incarcerated at 3 times the rate of straight people. 1/6 of trans people have been incarcerated at some point in their life, and nearly half, 40% of Black trans people have been incarcerated. So looking at these numbers, we see that 18% of white people are harassed by police, as opposed to 38% Black. And this, I hope, comes to no surprise to most of us. I mean, if we are watching TV, if we are working with these communities, right, we know these things exist. We know these are real problems that they're navigating. And again, all we can do in these situations is show up in our best self, be informed, and be able to provide an intersectional approach to validation and connection, and really helping them get the support they need. All right, so I'm going to switch gears here too and talk a little bit about a person-centered crisis continuum. So kind of with those stats in mind, we know that because LGBT youth and BIPOC youth are experiencing higher rates of mental health crises, they'll likely have higher rates of contact with police, which can be detrimental for a community that already experiences high rates of criminalization. So with a person-centered crisis continuum, we can see that this model is going to allow for a lot to happen here. So the person-centered crisis care continuum gives the person maximum autonomy in a crisis situation, because it includes and considers the person's strengths, supports, and skills, overall reducing institutional crisis intervention. So in this first circle right here, where we are seeing a person-centered max autonomy, blue, right? This is where the person has the utmost autonomy. Ideally, the resolution of this crisis is happening within the center circle of this being led by the person in crisis. Often for this to happen, it requires preventative work. This means that we need people to be taught and to learn skills and tools that can help them regulate the crisis themselves without needing outside intervention. Tools that are especially helpful here can include some of the distress tolerance skills that are taught in dialectic behavioral therapy, such as the stop skill and the tip skill, which I will dive into a little bit later, and EMDR skills such as bilateral simulation, which I will also go into. This can also include the safety plan and other skills and tools that can help the person in crisis regulate that emotion on their own, or help them by getting that support from the person that they trust, right? So the second circle here, the yellow circle, represents the steps that we take when the individual in crisis isn't able to regulate the emotion, or their own supports are not able to help them. For example, tools that would be included, or tools and resources that we would include here, would be warm crisis lines, community local crisis response teams, clinics, outpatients, kind of some of those things I talked about early on. Then we have this third circle, which is the institutional crisis intervention, which represents the options that give the individual in crisis the least amount of autonomy, and include institutional crisis response like inpatient psychiatric hospitals and justice systems. Ideally, in a crisis situation, we're able to de-escalate the crisis before we arrive to that third circle. So for the rest of today, I'm going to focus on how we can avoid arriving to that third circle, because again, a major goal is to ensure maximum autonomy for persons in crisis to avoid criminalization. But how do we do that? So how do we get this model to be more of a norm as we reform the current system? So I'm going to be pulling from an ACT Quick model. So it's an acronym which I'm going to dive into. But before I get into that, where does ACT Quick come from? So when I was working in wraparound, I worked with a neuropsychologist by the name of Dr. Paul Baker. He developed a training called the person-brain model, which is a framework for multiple theories that include behavioral, humanistic, relational, person-centered, psychoeducation, and psychotherapy. So he kind of developed this training that's rooted in these things. And at the end of that training, he talks about how ACT Quick can be used as a model to kind of help someone in crisis. He believes that every time we interact with a youth, a new opportunity for healing and transformation is possible. So at my current role in the clinic, I'm the behavioral health provider. So I didn't only use this model with my families in wraparound, but I also use it here as a guide when managing crisis situations in the clinic. So I'm going to take you through each kind of acronym here, and I'm going to break that down. What could that look like in practice, not just in theory? So I'm going to do this by providing a case example. All right, so at the clinic, very often I will provide the therapy, or if I'm in the consultant role, what that looks like is doctors will call me down and kind of say, hey, this person's experiencing a lot of depression, maybe you can provide them some resources or education, or they're experiencing a lot of anxiety and they just need some skills that can help them until their follow-up appointment with a psychiatrist. So that's very often what I'm doing. So, within my first 3 months on the job, I was upstairs in my office and I received a page from one of the doctors downstairs. And she said, hey, want to let you know, I have a Black woman who is currently kind of agitated and she's expressing suicidal ideation. I tried to safety plan with her and she just got more irritable. Do you think you can come down and help me? So of course, I'm like, okay, sure, this sounds easy. So as I'm walking downstairs to meet this new patient, I'm taking into consideration the information that I have, right? And at this point, I just have, she's kind of agitated, she's expressing suicidal ideation, and she is a Black cis woman. So that's all the information I have going in. Well, I happen to meet Brittany. So for the sake of this training, I'm going to use Brittany's story as a case example to help us understand how the implementation of ACT Quick can be used. So Brittany is 22 years old. Like I said, she is Black. She identifies as a woman. However, she does identify as queer. When I get down there, I kind of ask her what's happening, and I'm finding that she's very triggered and activated right now because she's forced to live with a sibling who triggers her PTSD. Right, so her sister reminds her of her mom. Her sister also reminds her of her childhood, and this person had also experienced a lot of trauma in early childhood. So I could see how being forced to live with your sister at 22 can trigger your PTSD. So some of the vulnerabilities that I kind of got in the conversation and with information from her was that she is a Black woman in a predominantly non-Black area. Here in Santa Barbara County, it's, diverse in some sense, but for Black folks, they are a small percentage of folks that take up space here. At the University of Santa Barbara, I believe it's 2% of students that attend there identify as Black. So that's one thing I'm considering. She had just moved to this city, so I'm assuming she probably doesn't have a lot of contact with friends or natural or community resources. She had recently been sexually assaulted, which had resulted in 2 psychiatric holds in 1 month prior to her move-in care. So the sexual assault that she had gone through had really kind of sparked or heightened her mental health symptoms. And as I got to know her, I found that the approach she took to get help on this, many systems were invalidating and unsupportive. That included the psychiatric facilities she attended, law enforcement that she had called, crisis hotlines that she had called, friends that she had tried to get validation from. So this landed her kind of needing to move out of the city and being, again, forced to live with her sister. She discloses to me that she had a history of borderline personality disorder that resulted in vocational and interpersonal impairments. So when I met her, she had told me, like, because of my mood, and sometimes I get really mad, I tend to, like, in quotes, like, pop off on my boss, my supervisors. I don't like anyone telling me what to do at times. So she had, like, every 2 months was kind of transferring jobs. And then the interpersonal impairments included not just with her, like, sister and her mom, but also housemates, professors, right? So when I met her, she was in school, and I've been working with her for, I want to say, 9 months now. And in those 9 months, she has decided to drop out of school. She was in her senior year and only had 2 classes left, but she had a meeting with a counselor. That counselor offended her, and she ended up saying, I don't need to go to school. I'm just going to work. So that's kind of how some conflict for her can very often lead to a crisis and impulsive decisions. I will say, though, that this decision she made, although it was rooted in, like, her emotion kind of being heightened and impulsive thinking, it is something that in time she's come to realize that it needed to happen just so she could explore who she is. But yeah, that's kind of some of the vocational and interpersonal impairments. So again, what this looked like when I saw her was at a doctor visit, she expressed extreme hopelessness. At our clinic, we do for every intake we do a anxiety scale. So the GAD-7. And then we also do a depression scale, the PHQ-9. And on this, she had scored high in both. And this kind of led to a conversation with her and her doctor saying, hey, I noticed these scores are pretty high. This can look like depression and anxiety. And so as she began asking questions, that's where Brittany began sharing, well, this is what's happened to me. This is why I'm upset. And then it led to some statements around, I don't even want to live anymore. I just want to kill myself. I don't want to be here. And she became agitated as the doctor was trying to safety plan. So again, the doctor calls me and I go in there. Okay. So that is kind of the situation that I'm having to walk into. And already I'm thinking, I need to be keeping my act quick hat on. So what the A stands for is going to be assess the brain state. So in this, we're going to want to look at what is the person doing, what are they verbalizing, do they have logical-based behaviors, survival-based behaviors, so are they argumentative, are they reactive? And based on my assessment of the brain state, that is going to kind of dictate what direction I take in terms of intervention, right? So in order to do that, we have to understand a little bit of what brain states can look like. So I'm going to go ahead to the next slide here. So as you can see here, this is the triune brain, 1 mind, 3 brains. So in this model right here, we're seeing that the brain is kind of divided into 3 states: executive state, emotion state, and survival state. When I was trained with Dr. Paul Baker, he kind of added to this theory. A lot of his research kind of builds on these brain states. So he built off the 1960s model, the triune brain, which was developed by an American neuroscientist, Paul MacLean, in 1960, which again divides it into 3 regions. He suggests that the human brain is organized into a hierarchy, which itself is based on an evolutionary view of the brain development. So we kind of have these 3 brain states. The first one is going to be the survival brain. So the survival brain, it is the part of the brain that detects a threat. I always say this is where anxiety can live. This part of our brain regulates our automatic functioning, heartbeat, eating, sleeping, crying, temperature. So this is why when we are anxious, sometimes our body will, breath will be irregulated, our heart rate will increase, we have difficulty sleeping, we get change in temperature, sweating palms, right? So this is kind of an indicator that we may be in our survival brain. So what we all know that when we experience crisis, right, our brain goes into the fight, flight, freeze, or fawn. So this is a non-thinking brain. It is our reactive brain. It is activated and turns on and off depending on the situation. So as we know, in order to help someone de-escalate, some of the strategies we might use are going to be keeping a calm voice, listening to the person, expressing support and concern, right? We need our affect to kind of match theirs. We may need to avoid eye contact that's continuous because that might be uncomfortable. We may avoid touching the person unless you ask permission. We'll want to be patient, gentle, give them space, don't make them feel trapped. So that's what we'll want to do when someone's in survival brain. The emotion brain. So the emotion brain, this is where I say depression lives, or when someone is in a heightened state of emotion, this can often be the part of the brain that's activated. So it is the response to being upset and can only be soothed through connection. An upset emotion state is triggered by the world not going our way. It limits our ability to see from another's point of view. The upset unconscious state keeps us on autopilot, so our words and tone match those of key authority figures from our childhood. We revert to disciplining the same way we were disciplined, even if we know this behavior to be ineffective or hurtful. So the emotion brain asks the question, am I safe? Am I loved? Am I accepted? Overall, can I make a connection, right? So we have survival brain that's kind of asking, am I safe? The minute that person feels safe, we're going to see anxiety drop. Then we might be able to get to the emotion. And then once that person's able to, or we're able to help the person identify the emotion, we might seek to validate that and try to connect with that person. Because again, how many of us have been upset, and the minute we feel understood by somebody like you get me is when we see our frustration go down. So this brain state is really important to validate, to find ways to connect. And in order to do that, we do have to have an intersectional lens on. We have to be self-aware of what we bring into the room, what the other person may be experiencing, because that is going to allow us the ability to truly, truly connect. And then we have our executive brain. So this is where we are not only surviving, but also thriving. And we seek to understand in this brain, what can I learn, right? So this is where we want everybody when we're working with them to be. But the reality is that a lot of the folks we're working with, because they may be navigating systemic forms of oppression, stress, poverty, mental health, this is not always the brain state they're in. When we are in this brain state, we can regulate our emotions, we can pay attention, we're good with our time management, we can be organized, prioritize, we're able to have empathy. And more importantly, we have our impulse control. We can seek to achieve our goals. And so this brain asks, what can I learn, right? So when someone's in this brain state, I think this is a great time for us to, talk about the safety plan, develop a safety plan, what triggers you, what gets you mad, how do you handle that? What can you learn from this last incident of a crisis? So that is going to be the executive brain. I'm going to review this timeline in relation to the brain states. So this is the stress model of crisis building on the therapeutic crisis intervention training developed by Cornell University, which helps us understand the person in effort to implement de-escalation techniques and provide moments for coaching and teaching skills. So I went ahead and added the brain states to kind of help put things into perspective. Right, so this is kind of the stress model of crisis. So we may be intervening with someone in a crisis at any point in this model. So the pre-crisis is the baseline. So this is typically someone's baseline. This is their normal behavior we're going to see. So again, ideally, if they're in their normal brain state, they may be an executive brain. So right here, it can be best to begin, starting a safety plan. Hey, hey, is there any crisis we would anticipate? Anything like that that could come up? And if so, what can that be? Then we'll have a triggering event, right? So this can be any situation in which the person feels challenged, frustrated, stressed. Maybe they've been exposed to a trauma trigger. Maybe there's some environmental things going on or some psychological factors, not getting what they want, a breakup, failing a test that was really important. So in thinking about Brittany's experience, right, she had already shared the triggering event for her was having to move with her sister after being assaulted and put on 2 psychiatric holds. So that was kind of information that I got. So I'm going to take it to this next one here, the escalation phase. This may be where the person starts to get aggressive. So the escalation phase is kind of when the emotion brain is activated, right? Is when that trigger has activated an emotion that's really, really strong and kind of hard to control. Again, our front brain shuts off, and then we're kind of just left in this heightened state of emotion. So in this, there may be clear signs of anxiety and inability to cope with these situations. This may be someone who's really depressed, hopeless, withdrawn, someone who's yelling, cursing, calling names, damaging property. So that may be what we see in this brain state. Again, it is when this emotion is so heightened that the person is really trying to cope and it's coming out in an unhealthy way. So with Brittany's case, again, I knew what triggered her. The escalation for her didn't look like outward aggression, right? She wasn't trying to hit the doctors or punch anybody or run off. She was just in a very heightened state of emotion, of hopelessness. So for her, this really wanted to be suicidal ideation, or just I don't want to be here. I want to withdraw. I want to run. I want to move. That is kind of how she presented. Then we'll have kind of an outburst crisis. So right here, the person's verbal and nonverbal behavior become dangerous and unsafe towards others and self, right? So this might be, I'm going to harm myself, and I have a knife and I'm going to do it. This may be someone who's now, going from hitting themselves or damaging their own property to now kind of hitting other people, breaking things. And that is when they are in survival brain. So in that, there is no intervention really that can happen in the outburst. What we need to do here is allow the behavior to kind of happen. The body will not kind of stay in this state for a long time. According to various different theorists, they say, 20 minutes is a good time for the brain to stay in that. And this is assuming that someone's not using any illegal substances or mind-altering drugs, that baseline is going to come down. So in this state of the outburst of the crisis where the violence is happening, we want to ensure, what does the red survival brain ask? It asks for safety. So we got to make this person feel safe, because when they feel safe, they're going to go back down and be able to maybe be in their emotion brain, and then be able to tackle the emotion, validate that, develop a plan, and now we're going into the recovery phase. So again, in thinking about Brittany's brain state, right? So I go downstairs to see, okay, act quick. I need to assess the brain state. And I'm finding she's not combative. She's not trying to fight, flight, freeze. She is really just in this heightened state of emotion, and expressing some hopelessness and suicidal ideation. So because I know that she's an emotion brain, the emotion is activated, I have to find ways as a clinician to validate that. So that was kind of going to take me to the next one here. So we have C. We want to calm the individual and the environment. So once the survival brain is activated, we want to make that person feel safe. So that may be clearing the area, allowing that person to come back down. However, for Brittany in this case, she was calm. I mean, like she was expressing suicidal ideation and she was a little agitated, but she was in a state where we were able to talk and kind of be in conversation with one another. So in order for me to calm the situation and the environment, because we're out on the floor when I meet her, you know, there were people walking around. The doctors are asking when the space is going to be clear. So I tell her, you know, why don't we go upstairs to my office, which I have set up very, like a lot of people say it's very relaxing, right? I have a couch, the lights are very dim. I have a lot of art around, crystals and little rocks. So she felt very relaxed. And again, this is a neutral space to her. She had never been in this space. So, you know, I'm like, hey, I understand, you know, you're feeling a little hopeless right now. I'm wondering if you want to head upstairs to my office so we can just have, you know, a little bit more like privacy. And I really want to hear what's going on here. So of course she was more than willing to do that. And then that leads to the T in ACT, right? Which means talk with the individual. And so as I'm going to talk with her, I want to make sure I'm taking an intersectional approach because she is an emotion brain. So I need to find ways to connect. And I'm going to connect with her through conversation, these verbal and nonverbal interactions. So I want to make sure I'm definitely able to validate and connect with her on some level. Because that I know, if I can validate, if I can connect with her, I am going to bring her out of this emotional state and then get her to executive brain where I can now help her. Kind of like I said, when we're doing this, we need to be intersectional. So she is a Black, cis, queer woman that I am coming downstairs to help. I am a brown trans man. And I will say, when I first met her, I did not know she had identified within the community, right? That information wasn't given to me off the bat. So I didn't even think to ask her because she had presented like very cis female. So there wasn't even a question. So when I get there, I take the intersectional approach, which means I have to like acknowledge my layers of privilege, because that is kind of the most culturally sensitive response I could give. So I said, you know, hi, gonna work with you. Let's head upstairs. How do you feel working with a brown trans man? And she was like, I'm fine with it. And then she said, oh, you're trans? That's cool. I'm queer. And so that kind of allowed for us to connect on like, maybe not on race, but in terms of sexual orientation in the community. She kind of felt validated there. And, you know, I said, hey, I just heard you moved here. And I know that, you know, it can be hard to like just move and start all over and have to meet new people. And she was very like, yes, yes, it is. And then she kind of vented about her sister. And she wasn't forthcoming with like the sexual assault history at this point. It was just, yeah, I'm really activated. I hate that I have to live with her. I hate my life right now. I just don't want to be here. So just kind of giving her that space to vent, validated that it must be hard to be around her sister. It must have been hard to have to move here. It must be hard when, you know, it can be hard to find community in this space. It must be hard being that we are in a pandemic where a lot of things that would typically be accessible, like resource centers, groups, those things are active in Santa Barbara, particularly for our LGBT communities. We have 2 agencies that do this work, and both of them are only providing services on telehealth. So that's groups. And a lot of people have given me feedback that like the groups they aren't helpful when they're on Zoom. People want to be in person. Why? Because we are humans, we are hardwired for connection. And being in community with other people, this goes to like an AA model, right? That when we are in community, the power of peer support groups is super important in building resilience. So just kind of able to validate that, but again, taking an intersectional approach. And so this slide right here, it says every time we meet, well, let me just move this here. Okay. Every time you meet with me, meet me with kindness, care, acceptance, compassion, grace, friendship, validation, joy, love, in situations in which I have been met with anger, judgment, ridicule, exclusion, abuse, criticism, blame, abandonment, punishment. In the past, you helped me heal. I heal. So I like this, right? Because this slide right here just kind of reminds me why it's important for us to have self-awareness. So in order to, calm an environment or get someone to talk with you, we do have to be able to be self-aware in these situations. We have to know, like, what do I bring into the room? What are your thoughts and opinions, and how can that come out in verbal and nonverbal communication? So some questions that we may ask in taking into account self-awareness, intersectionality, these may be questions we want to consider, right? How does this identity, whether it's my identity or their identity, influence how I think and how I behave? How does this identity influence how others may think or behave towards you? Because this can often impact connection and influence someone's sense of self. And then you may ask someone, right, or yourself, how often do you think about this identity on a rating scale? So be able to validate each experience. So for this person, right, for Brittany, when she had come in, some of the things I thought about were, how does my identity influence the way she'll think or behave, right? Well, I thought I could present as a cis male in some cases, passing, or even disclosing that I'm a trans man. If she had had feelings towards that, that might have impacted her ability to connect with me. Maybe she might have been really religious or didn't believe in the trans identity, right? That might have been something that could have impacted us. How does this identity influence how others may think or behave towards me? Like I said, the fact that I'm trans could have impacted that, but in this sense, it didn't. So those are just kind of some of the things I'm thinking about. I'm brown, I'm a male, a trans man. And so am I going to truly be able to, validate and show compassion? I'd like to think I did that, but again, this was one case where kind of that disclosure worked. So the next thing I want to talk about is just kind of, again, hitting on that intersectionality, because we didn't go into it a lot in this session. But intersectionality argues that various social identities, including race, sex, gender, sexual orientation, class, ability, amongst others, overlap and intersect to create distinct experience with privilege and oppression. Right? So for her race, being Black in a predominantly white neighborhood, she's a female, and a lot of things we ended up talking about in further sessions related to like her experience as a female navigating misogyny, patriarchy, oppression just because of her sex. Then her sexual orientation, right? She talked about identifying as queer and how often, this orientation impacted her relationships with her family. They impacted her relationships when she dated men, cis men, her class, right? She came from an extremely poor family. And so that was also why she had to live with her sister, because when this happened, she couldn't find a place to live. She did not have the money for a down payment, 2 months rent saved up, or even a credit score that would get her housing on her own. So she had to come and live with her sister. Luckily for this person, she did have privilege in that she was able-bodied. She was able to walk, talk. She had all of that. So that kind of helped. Other things that might have impacted her, right? Again, taking into account the geography she's in, living in Santa Barbara, the fact that she had been shamed and blamed for the abuse that she had went through, that she was in college. So this was just me kind of taking an intersectional approach, and we're always going to want to take an intersectional approach when we work with anyone, because intersectionality argues that each individual has multiple points of privilege and oppression that impact their experience in society. So that means we have to consider these things when we are supporting people through this crisis. So take these things into consideration and acknowledge them can be so validating for a person. It allows us and the other person to identify areas of privilege and oppression that we have. Okay, so that is a little bit on intersectionality, and I transfer to the next slide. Again, I want you guys to think about, like, what do you bring into the room? How have layers of your identity impacted the clients you've worked with, the ability to connect with those folks? And again, this could have worked to your advantage, or it could have created a barrier, right? Like when I was working with wraparound, we often worked with brown families and we had white clinicians, and oftentimes as the brown supervisor on that team, there was feedback given from families that they would like someone who spoke Mixteco, but that's not something we had here. They would like families, for their child to work with a specialist that they could identify with. That could have been, that came up around, they want a female and not a male, or they would like a brown Latina staff as opposed to, a white staff. So just taking into those into account. Ideally, best practice is that we are treating individuals with folks they see themselves represented in, and this is coming up with the LGBT and BIPOC community, that they tend to have better responses to treatment and services and help when it's someone they can identify with, right? This is why a lot of agencies have paraprofessionals or peer supports, because I might not be able to validate a mother who's dealing with postpartum, but you know what? I'll link you to a staff that can. And the same goes on the other end. So this is going to take me to what we call the bilateral simulation. So before I dive into this, I want to say, with the case study of Brittany, right? Brain state, emotion, calmed the environment by taking her to my office where it was very relaxed, neutral space. Then I got her to talk a little bit about what was happening. And that is where I got all of the information, and with a listening ear and compassion and those nonverbal, I hear you, I was able to validate a lot of her experiences. And I think in this situation, I was able to bring her to a brain state of executive, because before she left, we were actually able to get a safety plan going that had plans for what she could do when she was activated. So we did not need to call law enforcement or initiate a hold. This was her willing to say, okay, I'll work with you to develop a plan, because I feel so validated and I feel so seen. There have been cases where sometimes that does not work. So we will have to try a different approach. So with eye movement desensitization reprocessing, one of the skills that's taught there is a bilateral simulation, right? So when we do eye movement desensitization, the clinician, the therapist, is using their hand or a light or a tool to move one's eyes back and forth, which mirror the process that happens in REM sleep. When we are in REM sleep, studies show that our left brain and right brain are in communication together. So our right brain holds a lot of our emotion, our left brain is very logic solutions focused. And when we have a bilateral process happening, the pathways of that brain are open for communication that kind of create a well-balanced perspective. So it takes into account emotion and it takes into account logic. So when we do a bilateral simulation, we are able to access a wise mind, meaning I have balance between emotion and logic, right? So for my client, Brittany, in this situation, her emotion was hopelessness, feeling trapped, angry, and frustrated. Don't get me wrong, her situation sucked, but we were able to kind of get her to that ration of thinking, right? So one of our safety plan before she left included that she would use some skills, but also she had a time frame. I want to be out of here and save up this money by October. That is when she had planned to leave, and she was going to get into contact with a caseworker and some housing resources. So with that, I was able to alleviate the feelings of trapped and hopelessness with a little bit of logic that says, well, if we create a savings account and we tap into this resource, we're going to be able to resolve this thing that's causing so much distress for you. So for bilateral simulation, let me break that down. So in addition to eye movement back and forth, this is basically a process where both sides of the body are activated, moving in a rhythmic pattern. So what bilateral simulation can look like is going to be biking. When we're biking, our legs are moving bilaterally. When we walk, when we run, when we go on a treadmill, a Stairmaster, those are times that our body is shifting left and right. Then we get into the tapping. So you see that little heart with the hands around it. That is a tapping. So many of you have heard of tapping as a form of like bringing down our emotion state. But this can also be a bilateral tapping. So sometimes we're in a car and we aren't able to like run or ride a bike or move bilaterally in the way we might want. So when I went to my own therapy, my EMDR therapist had me do this as a form of tapping: left, right, left, right, left, right. So very often in my EMDR therapy, my therapist would tell me, as you're sharing this distressing experience and processing your emotions, go ahead and tap. Right, so I'd be tapping in session as I was sharing. Overall, that therapist was activating my emotion brain and my logic brain and trying to get me to a place of quicker, wise mind, as well as trying to reduce that emotional charge that I had. So that is how the bilateral works: left, right, moving in a rhythmic pattern to activate both brains so that they can communicate and come to a wise mind. This process can be used to help us desensitize us to a strong emotion. It can help us reprocess an experience that we perceive as traumatic, right? Or where we had a feeling of discomfort or a negative emotion that was associated with that event. We can go on a bike and think about that experience, and then our brain will give us a more positive outlook, because the brain is a hopeful brain, according to Paul Baker. And what he says there is that if the brain has the option to take on a positive belief system, it will, but it has to be given this option when the pathways of communication in this brain are activated. So that's kind of how we can use bilateral simulation to, again, help us regulate our emotion, help us reprocess the situation, and in a more positive kind of resiliency intervention, it can also be used to build resilience, right? So I do these trainings, and very often I can get shy or anxious. And every presentation I have, I've gotten better and better. But what I'll do is I'll go to the gym after a presentation and I'll be on the treadmill and I'll just process the emotions that came, the feelings of accomplishment, the, oh, that went well, that was good, I really like what that person said. And I'm just overall like building my confidence. So I'll be on this treadmill thinking about like, that felt so good to be heard, felt so good to feel confident, to feel competent. And so I'm pretty much building the brain's resilience. So this is a skill that is taught in EMDR and can be used on anybody, right? So when I worked for Wraparound as a crisis response staff, sometimes the kid would be in the room and I'd get there and I'm like, yeah, he was throwing things. And I would tell the kid, you know, we'd sit on the bed and talk about the situation and the emotions. And I found that when I did that, I was probably in these folks' house for like an hour, a little bit longer. But once I learned this, I got the kids I was working with, the youth and families that I was working with, to kind of tap into this bilateral simulation. So that looked like, hey, you know, I know some things just went down right now with you and your family. Like, why don't we take a walk around the block? And because right now I work at a clinic where I'm literally 2 blocks from a beautiful beach, very often I will tell someone who's expressing suicidal ideation or just an intense emotion, like, hey, you know, why don't we head on over to the park so that I can, you know, hear you out and see what's going on. And again, it's a strategy that I'm using to kind of help them get to the state of their emotions being regulated. And then they're able to get to my office after that 10-minute, 15, 20-minute walk and say, okay, let's go ahead and develop our safety plan, or let's develop a plan that can help you feel a little bit better than how you're feeling right now, and it works. So don't underestimate the power of things that we naturally have access to, and most of us can do, whether it's the tapping, the biking, or the walking. All right, so we kind of went over the A, which is to assess the brain state. C is to calm the environment, and T is to talk. So we went over that. Now, the Q stands for questions, right? So this is where you're going to want to question for depth and urgency. So in this, you may ask, how serious was this problem on a scale of 1 to 10? What occurred? Who was involved? How might you help get things resolved or prevent them from happening again? So very often, Q, U, and I may be done in a separate session. If you are a person that has to do crisis response, maybe this is part of your assessment that you have to complete, is kind of asking these questions. But if you're in a clinic like I am, where I don't need to do a full crisis or a risk assessment, it's more of like, I hear you, let's get you linked, and then let's develop a safety plan. And because at my agency, when someone has high rates of depression or anxiety, they're very often referred to behavioral health for therapy. So this is where I'll meet someone in a crisis. I may do the assess brain state, calm them, talk with them, and then the other two that we'll talk about. But the QUI usually comes in when I'm in my individual sessions. So for Brittany, once she got into my office, I was able to ask her some questions, right? But again, I wanted to be mindful of her brain state. Me asking these questions in session with her in our first encounter was really trying to get an understanding of what emotion was activated by the situation so that I could validate. So I did ask her a little bit of like, what brought you here? You know, how serious is this problem with your sister? Do you feel you guys can resolve it? Do you feel like there's anything that can help? And that's kind of where she said, you know, no, nothing's going to help us. This is a history in our family. So then I'm going to want to unwrap the meaning behind the behavior. So I'll ask questions that are related to why behind their behavior. Was there a conscious purpose? Was this an unconscious reaction? And this may very often be filled with, I don't know, right? Because a lot of times when folks are in crisis, they're not really understanding why they're so activated. So in this, I might, again, assess what might be driving this behavior. Was there a conscious purpose or unconscious reaction? So for Brittany, this one, I really had to ask her, like, why she felt so strongly around her sister. And then that's kind of where she like shared a little bit more of the history and how her sister activated her. Then we get the investigate the history investigation, right? So assess if what happened might be related to a pattern or a behavior. Has this happened before? Is this a new or unique situation? So in a follow-up session with Brittany, I did ask her, like, you know, have you ever had to live with someone that you didn't like? Is this a new situation for you and your sisters? Do you guys typically have conflict like this that's hard to work through? And this is where she shared, like, this situation was not new. She said, my sister has always been like this. She's never going to change. She gaslights me. She does not take accountability for her actions. She blames everything on her mental health and our childhood. And she had said, but I'm tired of blaming things on my childhood and my mom. Like, I want to heal. I want better. And this is why I can't be around my sister, because she doesn't want to change. So we found that for her, this history, this tension with her sister had gone back a while. It was a pattern that her and her sister had. It had happened before. She had talked about cutoffs, and then they would talk again for a family holiday. And then her sister would kind of, like in her word, weasel her way back in. But then her behavior would kick in again, right? So again, in asking these questions, questioning the depth and urgency, the meaning and the history, it's also adding for an additional layer of validation. for this person. So the C is to create that safety plan. So this will be something that either your agency will give you a safety plan that they require you use, or one that you have developed for yourself. In my resources, there is a safety plan that I have developed and I use. But overall, during a crisis situation, it can make a difference to have a list of tools, coping strategies, and resources patients can use to help them break the cycle of suicidal thinking. So safety planning research has shown, is the best practice for managing suicide risk. In one study published by the British Journal of Psychiatry, they said that safety planning can reduce the risk of suicidal behavior by 43%, as opposed to those who do not use a safety plan. Safety plans are evidence-based. They allow for problem solving, distress tolerance, for us to access skills. So in my safety plan, I usually ask, like, what are we worried about? What are the crises that could come up? So for this girl, it was her and her sister getting into more fights. What are the signs and triggers? She was very good at, like, well, I know myself, I start getting angry, I start clenching my fists, I feel like I need to get away from her, I don't want to talk to her. And then we talked about skills and hobbies. And she didn't have a lot of skills when I first met her, but she did like walking to the beach, she did like listening to music, she had a cat who she really enjoyed like cuddling up with. So that was kind of how, in asking, like, what are some things you enjoy? What are some hobbies, skills, things that help you distract yourself? That is how I was able to create a safety plan. And then I kind of said, who are the people you trust? Like, who are your core people? That can be family or not. And she shared, well, I have a lot of friends up north. And so we were able to like add those friends to the list. So for her, it was much more of like natural supports chosen family as opposed to like biological family. And then when we talked about like community resources, she's like, I'm new here, I don't know a lot or where I can go. So that was the work we had to do in our therapy, was to try to find more groups or resources that she could go to where she would feel connected. And then we had the plan, right? I would do a follow-up call and we'd have therapy. So we're always going to want to create a safety plan in any crisis. For Brittany, as I began working with her, I found, a history of PTSD. And so very often her anxiety was heightened and she didn't feel safe. And that is when the agitation would come out, I want to run, I don't want to be here anymore. So we developed a safe place, doing the tapping. So again, we built in her mind a visual safe space. And again, on the link tree, which I'll go over in a minute, there are resources there. But because she also had PTSD and had a hard time sitting with emotions because she'd act impulsively, another thing we ended up doing was developing a container, so that when something happened in her day and she wasn't able to see me for 2 weeks, she would go to her container. So she'd picture herself taking this problem and putting it in her container, which happened to be a treasure box. She'd put it in a treasure box visually, and then when she'd come to therapy, we'd kind of talk about like, well, what got put in the treasure box in the last 2 weeks, and then we'd process that with some tapping. So she would tap in session and we'd process. So we were able to kind of alleviate that stress by processing through some tapping in a safe space. So again, her survival brain was deactivated when she felt safe. And then the container allowed her to put that emotion somewhere so that when she got to session, she could tell me, I went 3 weeks without some suicidal ideation, or I went 2 weeks without any thoughts of self-harm, because she started using skills. And as many of us know, there can be many other skills that can help us, right? I know for me, I like to ride a bike. For Brittany that I'm working with, I also got her into biking just because of the bilateral. We live in a beach town, so it was very often like, you like going to the beach, like, let's add a bike to that. Let's add a mindfulness. Let's add, like, when you are at the beach, some grounding techniques, listening to the sound of the ocean, watching the birds, feeling the sun, the sand. And so those were things that have been added to her safety plan and have helped her regulate her emotions much quicker. So I've been working with her like 8-9 months, and she has just done so well there was sessions where she told me like, I don't want to talk right now. You're being too you're being too positive. So in that, we literally sat for 20 minutes in a session, just angry. And I was like, well, I'm here with you. And then the next session, right, she came back and she's like, that was rough. I just didn't know how to get out of that emotion. So we're kind of just been building on these skills. I met with her last week and we reviewed some of the skills she's done. And she was just so impressed with herself. She's like, I never thought I'd be able to control my emotions. I've broken things in the past. I've had to pay for it. I've been kicked out of my housing. And now she has a boyfriend right now who accepts her and how she identifies in all ways. And now we're working on how her cis white boyfriend can support her when she deals with racism in the community or microaggressions, because she talks about when she takes that on to advocate for herself, that she can get very worked up. And she's very aware that like as a Black woman in Santa Barbara, like they'll call the cops on me. So she is really working right now to have her boyfriend say, hey, you know, these are things that get me upset. Like when I hear the N-word, when I'm sexualized, like these things trigger me. And so we're talking about how her boyfriend can use his privilege to support her so that she can get validated and feel connected and safe with her natural supports. The tip skill, this is something that's taught in DBT, and it's, you know, changing the temperature of our face with cold water. What that does is it slows down non-essential organs and redirects that to the brain and the heart, which can help us regulate our emotion. Intense cardio or exercise, right? This kind of matches with the bilateral simulation that says left, right in our brain. But this kind of intense exercise kind of just means like that adrenaline, cortisol that sits in the body can be put somewhere when we're anxious, agitated, or upset. And then, as many of you know, paced breathing as well as muscle relaxation can really help relieve tension in the body. And I think this one is one that we are currently working on, doing some paired muscle relaxation, because she is very like outward. She likes to like throw things and break things and punch things. So in the past, again, that led to a lot of property destruction of her own personal stuff. But now she's really working to just like channel it on her own. And again, bilateral simulation for her is something we've added. She likes to go biking. She likes to walk on the beach. She has done the tappings for her safe space in her container when she's activated. And then she uses the tappings in session when we don't go on a walk and she just wants to sit in my office. We do the tappings there. The keep in touch is the last part of Act Quick. And again, this is going to be based on your agency. For my agency that I'm at right now, they do not allow for us to like send text messages, or it can only be a follow-up call the next day and then therapy sessions. So that is how I kept in touch with her. I said, you know, no, thank you for talking with me. Like, how about I give you a call tomorrow just to see how your day's going, how the night went, and then let's get you scheduled for a therapy session. So that was kind of how we ended our initial interaction. But in previous jobs like wraparound, we were able to be a little bit more creative. So I had access to like texting patients, sending letters in the mail. We did drop-offs with like food gift cards or movie baskets or like games. And we'd say, hey, you know, just thought we'd bring this for you and your family so you guys can play Connect 4. So it is, that kind of will depend how you keep in touch. But overall, the skills that I reviewed today and the tools that I went over can be found on this link tree. So these are the 5 resources we'll have there, but the Act Quick model has been helpful, has been a helpful tool for me in building toward a world that doesn't rely on prisons and policing for mental health issues. It also allows for more autonomy and agency for people in crisis because they are able to rely on their natural supports and to name the things that work for them through the safety plan. So in here again, you'll see assess brain state. Can they engage? Brittany, yes, she was able to engage. I was able to calm and talk with her. She kind of reduced in agitation. Then I could have used some skills here, but I didn't need to. So we started developing the safety plan. Did she have access to one? No. So then we developed one. So this is, again, just one way to rebuild this system, to change it, so that we're creating more approaches that are rooted in, community-based, family, friends, natural supports helping, as opposed to institutions like psychiatric facilities and incarceration. Again, this is just one way. And I want to thank you all for being here with me today and just kind of hearing how this one case, I was able to use the Act Quick model.
All right, and I think we're getting ready to end the session. Thank you everybody so much for joining us.